The Thoracic Oncology Group of Australasia, TOGA, is the leading new thoracic cancer trials group in Australia and New Zealand. We are a multidisciplinary and patient-centred group bringing together leading clinicians, nurses, allied health professionals, researchers and patient advocates within the community to deliver cutting-edge clinical trials and translational research in order to improve outcomes for our patients with cancers originating in the thoracic region of the body, such as the lung cancer, small cell and non-small cell lung cancer and mesothelioma.
TOGA is the leading authority in Australia and New Zealand for the study of thoracic cancers. We achieve results, and we do this by working collaboratively across Australia and New Zealand and with international peer groups. We actively seek the input of patients and caregivers across the whole process. We work together for the future as one community.
TOGA provides hope through research. Hope to patients with lung cancer and mesothelioma. Hope at every point of treatment. TOGA understands and supports the needs of thoracic cancer patients, not just of today, but also of tomorrow. We want to provide informed care to everyone in Australia and New Zealand. We believe that we can achieve this by providing education forums to healthcare workers and the community.
We have a multidisciplinary board including representatives from medical oncology, radiotherapy, thoracic surgery, respiratory medicine and consumer groups. Membership is open to anyone with an interest in research into thoracic cancers. Please go to our website for further information.
Good evening, everyone, and thank you for attending today's TOGA's educational webinar titled New Horizons in Extensive Stage Small Cell Lung Cancer. My name is Surein Arulananda, medical oncologist from Melbourne and TOGA's scientific committee co-chair for the small cell lung cancer and mesothelioma track. Today, we have 4 excellent speakers, all of whom are key opinion leaders in their fields, and Professor Nick Pavlakis, my co-chair, will join in on the discussion at the end. Before we start, I would like to pay my respects to the traditional custodians of the land on which we are gathered and extend that respect to all Aboriginal and Torres Strait Islander people. Today's webinar is sponsored by MGen, and on behalf of TOGA, I would like to sincerely extend them my gratitude. For decades, small cell lung cancer has been a difficult disease to treat. Difficult in that it responds well to chemotherapy in the beginning, but relapses within a short period of time, and with little response to pre-existing agents. However, as with the rapid growth that we have seen in lung cancers, we have seen more effective drugs and a more nuanced understanding of the disease biology, which is making great inroads into managing this disease. This plays nicely into TOGA's vision and mission, which is to eliminate thoracic cancer as a source of death, disability, and suffering, and our mission to prevent, treat, and cure thoracic cancers through research, clinical trials, education, and advocacy. Here is a QR code for you to sign up, and there are a lot of benefits for being a TOGA member, including attending our annual science meeting that has just passed. Here is our program today, and we will go into it in detail later on. Before we start, I would like you to please take on some polls. It's always good to answer some questions at 6:30 in the evening. So the first question is, how would you rate your current awareness of T-cell engagers and their application in small cell lung cancer treatment? A, unaware, B, aware, C, adept. Okay, moving on to the second question. What is your expected median overall survival time for patients undergoing DLL3 targeted therapy in patients who have progressed on platinum and immunotherapy-based therapy? A, 6 to 8 months, B, 9 to 12 months, and C, more than 12 months. We'll now move on to the third question. What are the symptoms of grade 1 cytokine release syndrome, or CRS? A, fever, B, nausea, C, headache, D, all of the above. Fourth question is, can you manage CRS in your center? A, yes, B, no. And the fifth and final question is, how would you manage grade 1 and grade 2 CRS? A, symptomatic management, including oxygen, antihistamines, antipyretics, and intravenous fluid. B, corticosteroids. And C, tocilizumab. Okay, now we'll get to the action. I will first like to introduce Dr. Rebecca Tay. Dr. Tay is a medical oncologist at the Royal Hobart Hospital in Tasmania. She completed a lung cancer fellowship at the Christie Hospital in Manchester, UK, and she is my small cell lung cancer and mesothelioma scientific co-chair of TOGA. And today, Dr. Tay will be talking about current treatment landscape in small cell lung cancer to set us the scene. Thank you, Dr. Tay.
Thanks very much, Surein, and thank you, TOGA, for the invitation to speak on the current treatment landscape in small cell lung cancer with a focus on immunotherapy. So these are my disclosures. So small cell lung cancer represents around 15% of all new lung cancer diagnoses in Australia. It's clinically characterised by a rapid doubling time and propensity for early metastatic disease, particularly to the CNS. Despite initial sensitivity to both chemotherapy and radiation, small cell lung cancer is unfortunately associated with a high degree of relapse and disease resistance. And unfortunately, small cell lung cancer also disproportionately affects those who are older and have poorer performance status, sometimes driven by the disease itself. And it's this group of patients who are underrepresented in clinical studies. And it was just really over 10 years ago that small cell lung cancer was made a major research priority by the 2013 Recalcitrant Cancer Act in the US, given that there was no real therapeutic advances in small cell for many decades. And we still use platinum etoposide for extensive stage small cell and concurrent chemoradiation for limited stage. And that has really shifted from 2018 with IMPAL 133, followed closely by Caspian, showing an overall survival benefit with the addition of a PD-L1 therapy to chemotherapy. And I think we're well and truly entered our immunotherapy age in small cell lung cancer with the recent presentation of Adriatic at ASCO this year, showing survival benefit with the addition of maintenance durvalumab following consolidation chemo-rads. So this will be the focus on my talks tonight. And hopefully after we've heard from other speakers, you're left with a little bit more hope in small cell with a number of emerging therapies. So as immunotherapy emerged as a treatment strategy for some cancer types, there was a lot of hope that immunotherapy would have benefit in this disease, given early experience with immunotherapy suggested greater benefit in carcinogen-associated cancers, and certainly small cell lung cancer has a high somatic mutation rate. Furthermore, the presence of paraneoplastic neurological syndromes, such as Lambert-Eaton or limbic encephalitis, really suggested an ability in small cell to elicit an immunogenic response. Yet, despite enthusiasm, the benefits of immunotherapy in small cell lung cancer have not been clear-cut, and there's certainly been a number of lows equal to some of the highs. And strategies which haven't yielded a improved survival include single-agent ipilimumab in extensive stage, maintenance PD-1, as well as PD-1 CTLA-4 strategies. And KEYNOTE-607 was also a negative study with a combination of pembrolizumab plus chemotherapy as first-line therapy. We also see some disappointments in limited stage disease, with the phase 2 Stimuli study not showing any PFS benefit, which was the primary outcome, following chemoradiation. But I will focus a lot of my talk on some of the highs. And we might focus on first-line therapy strategies in extensive stage small cell lung cancer, starting with IMPOWER 133. So this was a phase 3 randomized international study of first-line extensive stage small cell lung cancer, those patients with good performance status with no prior systemic therapy. Patients with brain metastasis were allowed on study if they were treated, and patients were stratified based on sex, ECOG, and brain metastasis. PCI was allowed at the investigator's discretion, but thoracic radiotherapy was not. So patients were randomized 1-to-1 to either the combination of atezolizumab plus carboplatin and etoposide for 4 cycles, followed by maintenance atezolizumab, or the control arm of placebo plus carboplatin and etoposide for 4 cycles, followed by placebo. Treatment was until disease progression or unacceptable toxicity, and co-primary endpoints was overall survival and PFS. So we can see here from the baseline demographics, they were evenly matched in both groups. I think we noticed that the median age is slightly younger than what we would see in the clinic, and the rates of brain metastasis were actually quite low, and like 9% in both groups. So IMpower 133 was a positive study showing the addition of atezolizumab to first-line carboplatin etoposide improved survival, with a median overall survival of 12.3 months in the atezolizumab group and 10.3 months in the placebo group. So although the absolute benefit is not large, we certainly see an impressive HR rate of 0.7, counting to a reduction in death of 30%. There was also improvement in PFS of 5.2 months in the atezolizumab group compared to 4.3 months in the placebo arm. And when we look at subgroup analysis, it's really most subgroups which benefited from the addition of atezolizumab, only from the slight exception of the group with brain metastasis with the HR just crossing 1. But this was a very, very small group, so really very exploratory. As we expect from a first-line study, there were high objective response rates, around 60 to 65% across both groups. But we noticed that the addition of atezolizumab didn't increase objective response rates. And we also see that, unfortunately, there are patients who are upfront refractory to platinum chemotherapy at a rate of 11% in the TESO group and 7% in the placebo arm. There were no new safety signals with the addition of immunotherapy in IMpower 133. As expected, there was a slightly higher rate of immune-mediated events at 40% in the atezo arm, but these were mostly grade 1 and 2. And as expected, the most frequent immune toxicities were rash and hypothyroidism. So we do now have long-term survival data from IMpower 133 from the iUmbrella-A extension study. So this study enrolled patients who continued to receive atezolizumab at study closure around July 2020, or was still in survival follow-up from those patients who were randomised to the experimental arm of atezolizumab plus chemo. There was actually only 18 patients in Umbrella-A, and 10 were still receiving maintenance atezo at the time of enrolment. But what we do notice is that the addition of atezolizumab does show a potential long-term and durable benefit in a select group of patients with a 5-year OS rate at 12%. And this is certainly a lot higher than historical controls of chemotherapy alone of about 2%. So moving on now to Caspian, and I would say these IMpower 133 and Caspian are very complementary studies. There are only very slight nuanced differences between the two, which we'll discuss, and a few other exclusions which impact our treatment decisions in the clinic. So Caspian, again, was a phase 3. It's actually a 3-arm study which enrolled patients with extensive stage small cell lung cancer, again, of good performance status. Patients with brain metastasis were allowed if they were asymptomatic or treated and stable. And this was a large study of over 800 patients who were randomised to one of 3 arms. So the first arm was a combination of durvalumab, an anti-PD-1, tremelimumab, a CTLA-4 antibody, and the choice of either cisplatin or carboplatin in combination with etoposide, followed by maintenance durvalumab. The second arm was a combination of durvalumab plus chemotherapy, and the control arm consisted of chemotherapy, either cis or carboplatin again, for up to 6 cycles. So PCI was only allowed in the control arm. It was not allowed in any of the immunotherapy arms. And similar to IMpower 133, thoracic radiotherapy was not allowed on study. The primary endpoint was overall survival. If we look at the 3 arms, they're fairly evenly distributed for baseline characteristics. I would say, for the exception of in the 4 for the 4-drug arm, there was a higher rate of brain metastasis at 14% compared to around 10% in the other 2 arms. If we look at the overall survival, mainly focusing on the durvalumab plus chemo versus chemotherapy arms, certainly the addition of durvalumab to first-line chemotherapy also improves survival, similar to IMpower 133. We also see very similar median OS numbers of 12.9 in the combination group compared to 10.5 in the chemotherapy alone arm. And at landmark survival analysis at 12, 24 and 36 months, we also show an improved OS rate favouring the durvalumab group compared to control. Looking at the subgroup analysis, nearly all subgroups benefited from the addition of durvalumab. And if we look at the comparison of durvalumab tremi plus chemotherapy compared to chemotherapy alone, there really was not any improvement in overall survival, and it did not meet statistical significance. So I've just put this up to show that sometimes in small cell, we want to use our best combination first, given that there's a high drop-off for subsequent therapies. So in both arms, there was only just over 40% of patients who received one subsequent line of therapy, and in Caspian, the most frequent second line was chemotherapy, and there was only 12 to 14% of patients who received 2 or more subsequent lines of treatment. Again, there wasn't any unexpected safety signals. We do see that immune-mediated events occurred at a rate of around 20% of any grade and 5% of grade 3 to 4. So really a comparison of, in Australia, we have availability of both atezolizumab and durvalumab based on data from Empower 133 and Caspian. They were both very, I think, complementary studies, as I've said, with similar median overall survivals and 12-month OS rates. I guess the major differences is that Caspian allowed the choice of either cisplatin or carboplatin, whereas Empower 133 was only carboplatin in combination with etoposide. PCI was allowed in Empower 133, but only 11% of patients who received atezolizumab received PCI, and it was actually not allowed in Caspian. Both studies did not allow consolidation chest RT, so this really remains an unanswered question with the benefit of thoracic radiotherapy to residual thoracic disease in the immunotherapy era. And Caspian did allow asymptomatic brain mets to be enrolled. So I suppose we always want to do better, given that only 12% of patients are alive at 5 years with the combination of PD-L1 and chemotherapy. Unfortunately, efforts to build upon that so far have been negative. This is the Skyscraper 02 study looking at the addition of tiragolumab and anti-TIGIT in combination with atezolizumab plus chemotherapy as first-line treatment in extensive stage small cell. And unfortunately, the addition of tiragolumab did not improve survival over PD-L1 plus chemo. I suppose this asks the question whether we need to look at other combinations. So ETA 701 was presented at World Lung last year, and this was a phase 3 study comparing benmalstabart, which is a novel PD-1 agent, with anlotinib, an anti-angiogenic, with chemotherapy in extensive stage small cell. The control arm would probably not be a standard of care now. It was carboplatin and etoposide, but certainly the 4-drug arm reported the longest median overall survival historically from any phase 3 study of 19.3 months compared to 11.89 months in the control group. I think what's interesting about this study is actually about 25% of patients were never smokers, and this is in a Chinese population. So it is difficult to see, how generalisable this would be in the Australian context. But I think it will be interesting to see some genomic analysis that comes out from this particular study. So I know our focus tonight is really on extensive stage, but I just did want to touch on limited stage, given that there's been some advances in this area. So despite us treating limited stage small cell with curative intent, unfortunately, we do not cure the majority of people with concurrent chemoradiation, with median overall survivals of around 25 to 30 months and 5-year OS rates about 33%. So the Adriatic study was presented earlier at ASCO this year. This was a phase 3 randomised double-blind international study enrolling patients with limited stage small cell lung cancer of good performance status who had not progressed following concurrent chemoradiation. PCI was permitted before randomisation, and we have interim analysis of the durvalumab versus placebo group. So patients were randomised to one of 3 arms: durvalumab 1,500 milligrams every 4 weeks for up to 2 years, or placebo, and a third arm has not yet been reported using the combination of durvalumab and tremelimumab. So the dual primary endpoints was OS and PFS. So baseline demographics, there's nothing too unexpected aside from a trend that we see emerging of generally a younger patients than what we would typically see in the clinic. And around 33 patients in the durvalumab arm completed 24 months of treatment. And those who did not, the most common reason for discontinuation of treatment was disease progression. So at first interim analysis presenting at ASCO, Adriatic met both primary endpoints for OS and PFS. Median OS was a quite impressive 55.9 months compared to 33.4 months in the placebo group. And median PFS was also improved in the durvalumab group of 16 months versus 9.2 months in the placebo group. So in the subgroup analysis, certainly all subgroups favour the addition of up to 2 years of durvalumab. And we do see an interesting trend emerging like we did in the Pacific study, looking at consolidation durvalumab in unresectable stage 3 lung cancer, that the earlier you start the immunotherapy, potentially this has higher benefit. Again, no new safety signals. We're always very interested in these studies at the rates of pneumonitis, and there didn't seem to be any increased rates of grade 3 and 4 pneumonitis in the durvalumab arm compared to placebo. There were higher rates, however, of patients discontinuing durvalumab due to pneumonitis compared to placebo. So Adriatic, I think, does represent a new standard of care in limited stage small cell lung cancer. We definitely see the magnitude of absolute benefit much larger than what we see in the extensive stage setting. And there's certainly a number of phase 3 studies which will read out in hopefully the coming months as well. So I think what's also interesting in small cell is that we continue to treat small cell as one disease entity, whereas we've made lots of headway in non-small cell lung cancer. And there's currently no clinically available biomarkers that help predict benefit to available therapies, being immunotherapy. So blood-based TMB and PD-L1 hasn't really shown any particular predictive benefit. So hopefully we'll hear from Kate about the 4 small cell lung cancer subtypes, which may have distinct therapeutic vulnerabilities. And there's also been some interesting targets of interest which are emerging, including DLL3 expression, B7H3 and SLFN11. So in summary, the current landscape in small cell lung cancer, really we see benefit for the addition of PD-L1 in both the extensive stage, which we have available and reimbursed in Australia with both the atezolizumab and durvalumab. We're hopeful for access in the limited stage setting. I think they're really, despite immunotherapy advances, there's still much more to do, and I look forward to the next wave of therapeutics and biomarker discovery to help move the dial forward in small cell. Thank you.
Thank you very much for that, Rebecca. There's a fantastic overview of sort of a fairly rapid, in some ways, slow but rapid advance, and this new data from Adriatic has certainly been quite eye-opening as well. I would now like to introduce and welcome Professor Michael Boyer. Professor Boyer is the CEO for the Christopher Bryan Lifehouse in Sydney. He's a thoracic medical oncologist, very well accomplished, and indeed has a PhD in cell biology. And Professor Boyer will be talking to us today about emerging options in extensive stage small cell lung cancer treatment, and an overview on this new therapeutic compound, if you like, BiTE technology, and some data from the recently published Delphi 301 study. Thank you, Professor Boyer.
Thanks so much, Surein, and it's a pleasure to be able to talk to you tonight. And as you said, it's the story of small cell lung cancer is interesting. It's sort of both slow and rapid. And if you look at a slide like this one, you see that although in the last decade or so there have been some advances, it was pretty slow for the 30 years or so before that, with really pretty incremental advances and things that we now, of course, accept as standard treatment. The advent of immune therapies obviously changed things a bit, but despite those changes, the sad reality is that the vast majority of patients, and certainly almost all patients with extensive small cell lung cancer, ultimately relapse and die of their disease. And there's certainly a pressing need for more effective therapies beyond the first line setting. And in fact, you might argue there's a pressing need for more effective first line therapies as well. When you look at a slide like this, you see that beyond the first line setting, response rates for treatments are relatively low, 16 to maybe 30% in the second line setting, 13 to 20% in the third line setting. And the thing that really drives it home is when you look at overall survival in these patients, and in both those settings, survival is well under a year. So what this is really telling us is that we have a lot of work to do to try and find better ways of treating this group of patients. In thinking that through, of course, there's another challenge, and it's already been alluded to by Rebecca when she pointed out that as a group, this is a group of patients that often have relatively poor performance status, often have other comorbidities. And so finding treatments that are even able to be delivered is a challenge. Now, one of the things that obviously helps meet that challenge is identifying targets that represent a good way of differentiating between normal tissues, normal parts of the body, and tumor tissues. And truthfully, it has been very hard to find appropriate targets. Something that has emerged in the last 5 years, maybe a little more, is DLL3 or delta-like ligand 3, which is an inhibitory protein part of the Notch signaling pathway. And it turns out that, in fact, there's quite a big difference in the way DLL3 is expressed in normal cells, where it's predominantly internal, versus tumor cells, and in particular small cell lung cancer cells, where it's predominantly external. So that has been taken advantage of. And in fact, the other thing that has helped in developing this as a target is the observation that actually almost 90% of small cell lung cancers have tumor expression of DLL3. And, the numbers vary, but a low of about 80% up to a high of maybe 95%. So having something that's expressed on the cell surface and that is much more highly expressed in tumor than in normal tissue makes this an attractive tumor antigen and therefore an attractive potential target. Now, that has resulted in fact, a lot of activity in trying to develop agents that target DLL3. And you can see here a list of the drugs that are in development, except for the one on the first row there, which is the drug that many people have heard of, Rova-T, which was an antibody drug conjugate that failed in a phase 3 trial, both in terms of its effectiveness, but also problematically in terms of its toxicity. Beyond that, though, the field has moved on really to immune-based approaches. And you can see here listed a number of drugs that represent bifunctional T-cell engagers, so made by a variety of companies. There's, in fact, a trispecific T-cell engager, and there are some drugs that are basically CAR T therapies. And to a greater or lesser extent, all of these drugs are in development. The one that is most advanced and the one that I'm going to talk predominantly about for most of the rest of this talk is tarlatamab, which was formerly known as AMG 757. And although this slide says it's in phase 2, in fact, there's now phase 3 trials, or a phase 3 trial that is in progress and has finished accruing. Now, what do I mean when I say a BiTE or a bispecific T-cell engager? So these drugs or this technology is effectively an immune-based technology, and typically BiTE agents are a construct that have an antigen binding domain, in this case, a DLL3 binding domain. And you can see right in the middle of the slide, that's represented by sort of the orange coloured blob. It has an effector, it has a CD3 binding domain, which is shown in blue, and then it has an effector FC domain. And the way these drugs work is basically by bringing a cancer cell, so you can see the small cell lung cancer cell in this cartoon, into close proximity with a T cell, and it creates a situation which can activate these T cells without relying on major histocompatibility antigens. And so it can activate T cells that leads, obviously, in the case of the T cell, to T cell expansion, and in the case of the cancer cell, to apoptosis. So that's the theory, and that's how these drugs have been designed to work. So what happens in practice? Well, tarlatamab, which is a BiTE, has been evaluated, first of all, in a phase 1 study, and I'm not going to talk about that study, but more importantly, and in a bigger experience, in a randomized phase 2 study. The design of that study is shown on this slide, and you will see that the randomization is between 2 different doses of tarlatamab, a 10 milligram dose and a 100 milligram dose. And once a dose was selected, there was a dose expansion cohort. And finally, on the far right-hand side of the slide, and I'm not going to talk much about this at the moment, but maybe when we come to the discussion we can, there was a cohort of patients that was managed in a different way with less intensive inpatient monitoring. Now, I should just point out what I mean by that less intensive inpatient monitoring is that in this study and in most of the tarlatamab development program, it was mandated that patients were observed in hospital, and it varied in the different studies, but for up to 48 hours after treatment for the first couple of cycles of study drug. And so that's what the reduced monitoring cohort is all about. So this study included patients with previously treated extensive stage small cell lung cancer. And those patients had to have had a platinum doublet and at least one other line of treatment. So they had to have had at least 2 lines of prior treatment. They were good performance status patients. And of course, if you think about any of your patients who've gotten to 3rd line treatment for small cell lung cancer, you'll realize that most of them, or many of them, don't have good performance status. And that's one of the issues that we can perhaps talk about later. And they were allowed to have had treated and stable brain metastases. Now, the characteristics in this study, and very similar to what Rebecca alluded to earlier, it's a younger group of patients than you might reasonably expect with small cell lung cancer. So if you look at the median age here, it's of patients in their early to mid-60s. Other than that, it's a pretty typical cohort, mostly smokers, overwhelmingly smokers, obviously good performance status. About 1/3 of the patients had had 3 or more lines of therapy. 2/3 had had 2 prior lines of therapy. The majority had had prior anti-PD-L1 treatment, and a reasonable smattering of them had very early progression of their disease, so within 90 days of first-line platinum therapy. And again, a reasonable proportion with brain and liver metastases. Along the lines of what I said, the vast majority of these patients actually had DLL expression, and that is in common with what we know about DLL3 in small cell lung cancer. So what happened? Well, this study demonstrated quite an impressive objective response rate, and you can see in either of the cohorts, the 10 milligram cohort and the 100 milligram cohort, the response rate was between 30 and 40%. The numerically higher response rate was in fact in the 10 milligram cohort. Predominantly partial responses, as you might expect, although at least some complete responses. And interestingly, and we'll come to it in a little while, for those patients that do respond, in fact, about nearly 2/3 of them were still responding out beyond 6 months. And that's perhaps one of the more interesting things about this drug, that when you do respond, you often have very durable responses. In addition, you can see there the disease control rate of nearly 70%. And when you look at a waterfall plot, as you see here for the two different doses, 10 milligrams over on the left, 100 milligrams over on the right, what you see is that with the objective response rate being about 40%, in fact, almost 2/3 of the patients actually had tumour shrinkage. And that included, interestingly, a couple of patients with undetectable DLL3. And we can perhaps have a discussion about to what extent DLL3 is even valid as a predictive marker in this situation. And so that's a fairly, in the second and third line small cell lung cancer setting, waterfall plots that look like this are in fact fairly impressive because it's not what we're used to seeing. The other thing which I alluded to earlier is that if you do respond, those responses often are ongoing for quite some time. And you can see this in these two swimmer plots, again, the two different doses, with a lot of patients still having ongoing treatment. And if you look at the top 3 or 4 lines there on the left-hand side, they are all responses that are ongoing, actually probably the top 6 lines, ongoing beyond a year. So this is a drug where people respond quickly. That's the little red triangles, as you can see. And the median time to response was 1.5 months. The median duration of response was not reached. And as I alluded to earlier, nearly 2/3 of them were still responding out beyond 6 months. Translating that into what it looks like in terms of progression-free and overall survival, you can see that the progression-free survival is in the order of 4 to 5 months. Obviously, where you have a small cohort of patients with longer durations of response, the median may not be the best measure of that. And in terms of overall survival, the overall survival in the 10 milligram group was out at 14 months. And again, that's a non-mature data set. So you can see there that out beyond about 9 months in that particular survival curve on the right, you've got less than half of the patients still at risk. So very hard to interpret what's happening out there. And so you just have to bear that in mind when you consider those survival curves. Now, one of the things that happens when you use drugs that can affect the immune system in this way is that you certainly can have some unique immune-related side effects. If you look overall at the adverse events, almost all patients had some sort of adverse event, and about half of them had greater than grade 3 adverse events, although most of those adverse events, the high-grade ones, weren't necessarily related to treatment. Patients were actually able to continue treatment with this. Now, if you look at the actual, on the right-hand side of this slide, the actual common adverse events, you can see that the most common one is cytokine release syndrome. And I will talk a little more about that in the next couple of slides. There are some other quite interesting side effects. Dysgeusia is real with this drug, and patients really do have alterations in their taste. Fatigue and lethargy happens, a little bit of anemia, and pyrexia, often, in fact, as part of cytokine release syndrome. So cytokine release syndromes are an interesting constellation of symptoms that are occur with this drug, and together with many other immune-related treatments, and anybody that's been involved in any sort of CAR T therapies will know this and be familiar with this. The good news, if you want to use this drug, is that the CRS that we see is nowhere near as bad as what happens with some other agents. The common sort of symptoms are fever, hypotension, and hypoxia. And as you'll see on the right-hand side, this is predominantly grade 1 and 2. And the other thing that's interesting about this is that its median onset is really in the first day. Hence, when I referred earlier to the fact that in this study, patients were observed in hospital, and that's because really all of the CRS happens in that first day. It usually resolves relatively quickly, and it resolves in almost everybody over that time. There's a small number of patients in this study who required a dose interruption, but were able then to continue on with treatment. Now, the way that cytokine release syndrome is managed was protocolized in this study, as you might expect, and it was predominantly supportive care, things like paracetamol, hydration with IV fluids, and steroids, predominantly dexamethasone. But in patients who had grade 3 or higher, and it was only grade 3 in this study, but grade 3 or higher CRS, tocilizumab was recommended and was used. And obviously, as you might expect, for patients who are hypoxic, they received supplemental oxygen, and rarely vasopressors were required. The other interesting and somewhat different side effect that can occur is a thing called ICANS, which stands for immune effector cell associated neurotoxicity syndrome. And that presents with a mix of confusion, impaired attention. You can get a tremor, and you can actually have motor findings or weakness or both. This occurs just a little bit later at about 5 days and can last for about a week or so. It is rare. So in the 10 milligram group, it happened in 7% of patients, and there were no grade 3 episodes, and led to discontinuation in 1 patient only. A little more common with the higher dose, and as you can see from the very first slide I showed you about this trial, it was in fact the 10 milligram dose that became the recommended dose to go forward with in this study. Now, the other thing just to mention quickly about both CRS and ICANS is it tends to occur in the first cycle, and you can see this in the top row for the 10 milligram dose, the bottom row for the 100 milligram dose. It's rare by the time you get to cycle 2, and it almost doesn't occur at all by the time you get to cycle 3 or beyond. Really very, very rare. And in fact, as you can see, if you look at those percentages, it's even rare in cycle 2. So this is really a problem from when you're starting treatment rather than when you're continuing on with treatment. So this study showed that 10 milligrams of tarlatamab demonstrated durable anti-cancer activity, a manageable safety profile, and produced a 40% overall response rate. And as I said, overall survival that's immature, but is encouraging. The side effects and the adverse events were really something that occurred early on and were generally easily managed with supportive care, and didn't really result in discontinuation. Now, of course, it's important to note that this is an uncontrolled study. As I said, the randomization was between 2 different doses of the drug. And so there is now an ongoing phase 3 trial comparing this treatment with standard of care chemotherapy. And And that's important, and obviously is the data that is going to demonstrate whether or not and to what extent this is a real step forward. Nonetheless, these results resulted in accelerated FDA approval about 3 months ago, and so this drug is being used. Now, very briefly, it's worth just looking at the landscape here, and you can see that, as you might expect, a drug like this is now moving also into earlier lines of treatment. At the bottom of this, Delphi 304 is the randomized trial that I referred to a moment ago. Just above it, Delphi 303 is a first-line study looking at carboplatin etoposide and PD-L1 inhibitor with all the addition of tarlatamab both in the induction and maintenance settings in that study. And I'll skip over that one in the interests of time. Now, just very briefly, I did mention earlier that there are a couple of other drugs of a similar kind that are being developed. They're a little bit behind where tarlatamab's up to, but the two that are furthest advanced is this one, which is a Boehringer Ingelheim drug that's being tested so far in a study looking at second line and beyond small cell lung cancer. And amongst 57 patients, there was an overall response rate of 26%, and that's now moving into that was a phase 1 study, and it's now moving into phase 2, and it's been given fast track designation. And then the other drug is the trifunctional or trispecific T cell construct. Very similar idea to the drugs I've been talking about up until now, except that it's got an additional albumin containing section in the middle of the drug that stabilizes it. This is very early on, relatively small numbers of patients, only 29 patients with small cell lung cancer, but nonetheless, there have been responses seen, and so that's going to, I'm sure, continue on with its development. So in conclusion, I think we're actually entering a pretty exciting time with DLL3 as an appropriate target for the treatment of small cell, or to develop drugs for the treatment of small cell lung cancer. And this new sort of engineered approach to treatment and the creation of BiTEs is a very interesting one, with tarlatamab, if you like, being the first of these agents producing encouraging results. Clearly, as I've said, this requires confirmation in a phase 3 study, and that's partly because of what I referred to as the fact that you need controlled data. And then, of course, the other important aspect here is the need to consider how generalizable results are, because clearly in these particularly early phase studies, you tend to enroll patients who may not be that typical of the patients we have to treat every day. And so understanding that is very, very important in knowing how best to use drugs like this. And finally, as I've indicated, there are other DLL3 agents that are being evaluated now, and I'm sure we will be looking at a lot more data in this area in the near future. So with that, I will stop and we can go on.
Thank you very much, Michael. We certainly are entering a whole new era, and some of the data that you've showed us today is very encouraging, especially in seeing that sort of activity in the later line setting. One will hope that the drug will become more, I suppose, more efficacious in the earlier line setting, and we can certainly discuss that later during the discussion. I would now like to introduce Dr. Sagun Parakh. Dr. Parakh is a thoracic medical oncologist at the Eliza Newton-John Cancer Center here in Melbourne, and completed his PhD a few years ago in novel therapeutics. Today, Dr. Parakh will be talking about gaps where there is a lack of clinical evidence in small cell lung cancer. Thank you, Dr. Parakh.
Thanks, Surein. And thank you, TOGA, for the invitation. These are my disclosures. Next slide. So I guess Rebecca's already outlined very nicely response rates in the first line setting. So with our current standard of care treatments, we know that the overall survival is only just over a year. And so what strategies can we use to improve outcomes in the first-line setting? Both trials that Rebecca talked about, the Empower 133 and the Caspian, didn't look at consolidation chest RT in a chemotherapy and immunotherapy setting. Next slide. And so together with my colleague Eric, we are running a trial, the chest RT trial, which is an Australian study. It's a phase 2 study, and we're looking at the effect of adding thoracic radiotherapy in combination with chemotherapy and immunotherapy in patients with extensive stage small cell lung cancer. Next slide. So it's a fairly straightforward thing where we're just including radiotherapy to standard of care treatment with chemoimmunotherapy, and we want to see whether the addition of radiotherapy improves response to treatment or not. So the primary objective of the study is feasibility and safety, and secondary endpoint of the study is overall survival, PFS, and patterns of failure. Next slide. So the study design was meant to be fairly pragmatic and fit in with real-world practice. So the idea was to enroll 35 patients with untreated extensive small cell lung cancer, and they receive either concurrent or sequential chest radiotherapy. This could be done either after between cycle 3 and 4, or at the conclusion of cycle 4 of the chemoimmunotherapy. And then the patients would go on to receive the consolidation immunotherapy. So 8 sites across Australia were participating, and as of last Monday, we'd enrolled our last patient into the study. The first interim analysis has shown that there were no safety concerns, and we're waiting for the second interim analysis in the next few weeks. Next slide. So I guess, again, Michael and Rebecca have spoken about this, about the need in the second line setting, and obviously there's no current standard of care in the second line setting. The median overall survival for patients in this setting are very poor, typically less than 6 months, and there are a number of prognostic factors which affect survival, including ECOG, tumor extent, and time of relapse after first-line therapy. Currently in practice, there are a number of agents that we use. There's a lot of variability in what drugs are used, intra-hospital variability, but however, the response rates remain very poor at about 10%. So there are some new therapies coming out in the second line setting, and Michael's already given a great talk about DLL3 targeting agents. And so my focus really today is going to be on other therapies, which are antibody drug conjugates. Next slide. So the first drug which is causing some interest is a B7H3 targeting antibody drug conjugate. So B7H3 is a co-stimulatory molecule. It's expressed in a variety of cancer cells, including small cell lung cancer. So this drug has got a topomerase 1 payload, and this is being evaluated in a phase 1, phase 2 study, essentially patients with metastatic solid tumors. These were not screened for B7H3 expression. So overall, 200 plus patients were screened, of which 22 patients had small cell lung cancer. You can see the doses that were evaluated, and eventually the 12 milligram per kilogram dose was taken for a dose expansion study. The key endpoints, as expected for a phase 1, phase 2 study, were dose-limiting toxicities, and the secondary endpoints are PK and immunogenicity. So majority of these patients, as you can see in the small cell, had received 2 prior median systemic treatments, and the majority had received chemoimmunotherapy. Next slide. So the median follow-up was just under a year. The time to response was fairly short, so 6 weeks, and the median duration of response was about 6 months. The objective response rate in second-line setting was 52%. So compared to our current standard of care, which is about 10%, this is very impressive response rate, and almost 5% of patients had a complete response. Interesting, there was no correlation between B7H3 expression and survival, which is a bit surprising given that you expect the mechanism of action of antibody-drug conjugates. The more antigen, you expect more binding and more response, but this didn't pan out. In terms of safety, 13% of patients experienced interstitial lung disease or pneumonitis, and majority of these were low grade. Next slide. So there is a phase 3 study which is looking at this drug versus physician's choice chemotherapy in the relapse setting, which is currently ongoing. Next. The next ADC is a TROP2 ADC. So we know that TROP2 is being investigated quite extensively in non-small cell as well as in breast cancer. And so this study was also evaluated in small cell lung cancer. And patients without, it didn't include patients with brain metastases. Patients must have had prior chemoimmunotherapy and obviously of good performance status. It was a single-arm study. They received the antibody drug conjugate day 1 and day 8 in a 21-day cycle, and this continued until disease progression. The primary endpoint was overall response rate. Next slide. So you can see again, the numbers are small, so only 29 patients were enrolled, but you can see some pretty impressive response rates of 37%, including 11 patients who had a partial response. The median duration of response again was just over 6 months and 63%. In terms of the safety, majority of patients had some grade treatment-related adverse events, and they were quite high grade. Almost 50% of patients had grade 3 toxicities. However, this did not lead to treatment discontinuation or treatment-related deaths. Next slide. So the next ADCs that's also interesting is an SEZ6 targeting antibody-drug conjugate. So SEZ6 is a protein expressed in small cell as well as other neuroendocrine neoplasms and in brain tumors. This antibody-drug conjugate has a topoisomerase 1 payload, and the phase 1 drug looked at this ADC as a monotherapy as well as in combination with an anti-PD-1 and chemotherapy. It was administered in a 3-weekly cycle. So 49 patients were enrolled, of which 22 patients had small cell lung cancer and 22 patients had neuroendocrine tumors, and there were a few brain tumor patients as well. In terms of safety, so again, most patients experience some treatment emergent adverse event, the most common being anemia and fatigue. And of those that were grade 3 and higher were mainly hematological. And interestingly, no pneumonitis or interstitial lung disease toxicities were observed. Next slide. So as you can see, the ABV V706 was highly efficacious across all the doses that they evaluated, and they evaluated 5 different doses. And you can see most patients had a response. The response rate again was just over 60%. And most of these responses were durable and still going on for over 6 months. Next slide. So I think that's all I had to really present in terms of the antibody drug conjugates. Yeah, thank you, Surein.
Thank you very much, Sagun. Firstly, congratulations for completing the recruitment for CHESS-RT. We look forward to the results. And secondly, this field is becoming very rapidly complicated, but some of the waterfall plots that you showed us are certainly unprecedented in small cell lung cancer. I would now like to introduce Professor Kate Sutherland, who is a scientific lab head at the WEHI here in Melbourne. Professor Sutherland has a strong interest in RAS mutant and small cell lung cancer mouse models. She has a PhD from the University of Melbourne and completed her postdoctoral fellowship in the Netherlands. She's also TOGA's Translational Committee Scientific Co-Chair. Today, Professor Sutherland will be talking to us about lab research influencing clinical directions. Thank you, Professor Sutherland.
Thanks, Surein, for the invitation. It's a pleasure to speak to you today about obviously a great interest of mine, which is small cell lung cancer. And I'm going to switch tunes a little bit, and I'm not going to show a lot of clinical trials, but talk about the underlying biology of the disease. And I think from this perspective, there's a lot of exciting new developments happening in the small cell lung cancer field. So as Rebecca beautifully introduced earlier, small cell lung cancer has ubiquitous mutations in tumor suppressor genes P53 and RB1. And so unlike lung adenocarcinoma, where we can stratify patients into different subgroups based on genomic alterations and alterations in oncogenes that are targetable, small cell lung cancer actually doesn't afford this benefit. So it's really, as you've heard, being treated as one disease. And so, I hope in the next 10 minutes that I'll be able to highlight some interesting new biology that I think moves us away from that one-size-fits-all model. So I think a really seminal paper that was published in Nature Reviews Cancer in 2019 shows not the stratification of small cell lung cancer into genetic subtypes, but stratification of this disease based on the transcriptional landscape of the tumours. And so I'll just walk you through this slide. So Charles Rudin and others published this work where they looked at the RNA, so the expression of genes across small cell lung cancer tumours, and what revealed from this study was that they were able to stratify patients into 4 distinct subtypes based on the expression of these transcription factors, ASCL1 and NeuroD1, PAL2F3 and YAP1. And so what was interesting, because we know small cell lung cancer is a neuroendocrine tumour, but this study actually showed that there was subtypes of disease that had strong neuroendocrine-like features. So these are the SCLs, the ASCL1 and the NeuroD1 subtypes, but there were also more rarer subtypes of small cell lung cancer that had lower expression of neuroendocrine features, and these were marked by the expression of PAL2F3 and YAP1. So this was a real shift in the field, and I think really gave us the first hint that potentially we had a high level of heterogeneity and we could stratify patients in a slightly different manner to what has been previously done. So the stratification that I showed you was based on expression at the RNA level. And so this is a study from MSK, again from Charles Rudin's group, showing protein expression of these transcription factors in a subset of limited as well as extensive stage small cell lung cancer patients. I think this is a study of 157 patient samples. And I think I just really wanted to show this immunohistochemical analysis to show that you can see high expression of ASCL1 in the ASCL1 dominant group, high NeuroD1 in the NeuroD1 dominant group, and high PAL2F3 in this PAL2F3 group. What they showed in this study actually was that they weren't able to detect YAP1 expression, at least in the protein level, and I'll come back to this concept shortly. So in this same study, you know, when we first saw that stratification back in 2019, we kind of had the idea that it would be one patient equals one subtype. But actually, nothing's quite as simple as that. And this study from Rudin and colleagues actually showed that the ASCL1 expressing subtype could be found co-expressed with the NeuroD1 subtype. So life is more complicated. So there were actually tumours, a large percentage of tumours that expressed portions of tumour cells that had both of these neuroendocrine markers. Again, this study showed that the POU2F3 subtype of patients, these are the neuroendocrine low group of patients, appears to be mutually exclusive to the ASCL1 and NeuroD1 groups. And this is likely due to these tumours potentially arising from a different cell of origin, although that has not been formally tested to date. So if you recall, just a few slides ago, I showed you that in this study by the MSK group, they failed to show YAP1 expression in patient tumours. This is protein expression. And what they were able to show in their study is that they did get high YAP1 expression in non-small cell components of tumours that had sort of a mixed small cell and non-small cell morphology. If we go back to Charles Rudin's study and look at how the YAP1 subtype was defined based on the RNA level, and you just look at the samples that were used to stratify this patient group, what we noticed was that actually a high number of these samples were actually derived from cell lines and not patient samples. And these are cell lines that were generated back in the 70s and the 80s by Adi Gazgar and colleagues. And we recently published a paper that did an extensive analysis of these cell lines and actually showed that these cell lines represent SMARCA4 undifferentiated thoracic malignancies. This is a new subtype of lung cancer that can mimic small cell because they can also express high levels of or express neuroendocrine markers. So in the clinic, this is often misdiagnosed as small cell lung cancer. So this YAP1 subtype is controversial. I think it's worth highlighting in the field. And this is a quote that I took from Twitter from Lauren Byers, who said that there is no YAP1 subtype. This is officially retired. So I think just from 2019 to 2024, the field is really constantly moving with, what is the nomenclature of these small cell tumours. So what's also been of strong interest is looking at the immune landscape of small cell tumours. And I guess historically, these are largely thought of as immune cold tumours. We don't see an extensive amount of immune infiltration. These generally express low MHC class 1 expression and PD-L1 expression. So again, through some studies looking at expression of components of the antigen presentation machinery, as well as markers that are associated with T-cell inflammatory signatures. A number of studies have examined these expression across both limited and extensive stage small cell lung cancer samples. And what has come out of this data is that in general, we have the ASCL1 and NeuroD1 subtypes have an immune cold phenotype with lower expression of antigen presentation genes, as well as T cell inflammatory signatures. But there is an emerging subtype called the inflamed subtype. So I think this has sort of replaced the YAP1 subtype, that where you see high expression of both antigen presentation genes and T cell inflammatory genes. And this is RNA analysis of some limited stage samples, as well as analysis from the extensive phase samples from the Empower 133 trial, which you heard about earlier in this meeting. And so you can see there's, this real inflammatory signature is more associated with this small group of patients. So the dividing of these tumours into these molecular subtypes has really allowed us to think about small cell and the treatment of small cell, I think, in a more personalised, treated manner. So this is not at all an exhaustive list of some of the targets that people are looking at, but I just wanted to sort of give you a flavour of some of the key findings and interests in the field. So might not be surprising to think that the inflammatory subtype would respond well to immune checkpoint inhibitors. And so this has been of interest, and you can see these inflammatory tumours have higher T cell infiltration. The PAL2F3 subtype is associated with a higher expression of BCL2, so may respond better to venetoclax and other BH3 mimetic compounds. And of course, what's of interest this evening are the DL3 bites that are, emerging in the clinic, and, their association or high DL3 expression has been more restricted to these subtypes, the A and the N subtype, that express these neuroendocrine features. And that's shown here in this immunohistochemical panel, where you see high DL3 expression in the tumours, and that correlates with synaptophysin and NCAM expression. So one of the recent studies published in Cancer Cell back in 2021 looked back at the Empower 133 trial. They had RNA extracted from around 270 patients that were enrolled in this trial. And then they prospectively stratified patients based on the small cell lung cancer subtype. And this data really showed us that those tumours with high inflammatory signatures responded much better to immune checkpoint blockade compared to the other small cell lung cancer subtypes. So this really probably is no surprise. So when you've got high T cell, when you've got high infiltration, you respond better to the immunotherapies. So I just wanted to highlight a couple, I've just got 2 more slides, which I think is important when we're thinking about the classification of small cell and potentially the design of therapies that target specific molecular subtypes. So I think one of the characteristics that's really emerging in the field is that these tumours are very heterogeneous. We're not seeing just one subtype, one small cell subtype within one patient's tumour. And there's a lot of emerging evidence as well using mouse models of small cell lung cancer to show that these small cell lung cancers, tumour cells are really plastic. So this is a study by Trudy Oliver and her group using a mouse model of small cell lung cancer, and they showed that while these tumours start out as an ASCL1 positive tumour, they actually can evolve into a neuro D1 and a YAP1 phenotype during disease progression. This is some data from my own lab looking at expression of ASCL1 and NeuroD1 within EBUS biopsy samples from patients. And what you can see is that, yeah, you can get co-expression of these two transcription factors within a tumour, but you can also get co-expression of these markers within an individual tumour cell marked here. So, you know, I think these tumours are constantly evolving, and you know they're a moving target, and so I think we need to keep these factors in mind when designing therapies. So just to summarize, I've just given you a very high-level overview that small cell lung cancer can be stratified into distinct subtypes, and this is based on their transcriptional profile and not on their driver mutation. The classification of these emerging subtypes, I think, really has the potential to guide personalized treatment approaches, and there's really a lot of work going on in this area looking to design personalized treatments for the distinct subtypes of small cell lung cancer. A lot of work, or a lot of what we know about these molecular subtypes comes from tumours that have been resected. So we know little yet about what the molecular features of this disease is like at different metastatic sites. So I think this needs to be taken into consideration too when thinking about the design of therapies that are going to also eradicate the metastatic disease. And I think some challenges still remain. So on the whole, we have a relatively immune cold tumour phenotype, but you know there is some variation across the subtypes. And I think there's been a real focus so far on conventional T cells, but I think there's a lot of new emerging biology about the roles of other immune cells that may also elicit an anti-tumor effect. I think we need to consider heterogeneity. It's not necessarily one tumor is one subtype, and you know we don't yet know how this will change from diagnosis to post treatment. And so this area is constantly evolving. Probably this talk will be superseded by a couple of publications next week, but I think you know it's been a really exciting area, and I think gives a lot of hope to you know how these tumours can be treated in patients. Thank you.
Thank you very much, Kate. It's amazing to see how much more nuance we are already starting to become about small cell lung cancer, and we're going to become more nuanced about it as well as we go forward. So now we're going to enter into the discussion, but before that, I would like to present you the result from the earlier poll, and then we're going to run a second poll to see if some of you have been paying attention. The first question we had was, how would you rate your current awareness? And it was sort of fairly evenly spread, potentially more towards aware as compared to those who are unaware. And we asked the question of what you expect the mean overall survival to be from DLL3 targeted therapy. And once again, it was fairly even spread across, with 30% saying 6 to 8 months, 43% saying 9 to 12 months, and 26% saying more than 12 months. We asked about the symptoms of grade 1 CRS, of which the vast majority said all 3 symptoms were included. And then it was interesting, can you measure CRS in your center? And I personally thought the answer would be more skewed towards no, but I guess it speaks to to who's potentially on the call, and the fact that more and more therapies are coming out, including hematological therapies where there is CRS. And lastly, how you manage grade 1 and grade 2 CRS, where we had half the participants saying symptomatic management, 38% for steroids, and 13% for tocilizumab. So we're going to run the poll again. And just to remind you, the first question is how you rate your current awareness of T-cell engagers and their applications in small cell lung cancer treatment. A, unaware, B, aware, C, adept. The second question, what is your expected median overall survival time for patients undergoing DLL3 targeted therapy in patients who have progressed on platinum immunotherapy-based therapy? A, 6 to 8 months, B, 9 to 12 months, and C, more than 12 months. Third question, what are the symptoms of grade 1 CRS? A, fever, B, nausea, C, headache, D, all of the above. Question 4, can you manage CRS in your center? A, yes, B, no. And the final question, how do you manage grade 1 and grade 2 CRS? A, symptomatic management, B, corticosteroids, and C, tocilizumab. And we have a little bonus question. Question 6, what is the one takeaway from the webinar that would change your practice and why? Now I would like to open up for panel discussion. And firstly, I would like to introduce my co-chair, Professor Nick Pavlakis, who is the chair of the TOGA board, medical oncologist from the Royal North Shore in Sydney. He completed his PhD a few years ago at the University of Sydney. So I might start by throwing this to you, Nick. We've seen some very exciting data, very rapid data in a short space of time. What do you make of the tarlatamab data that Michael presented? We've seen some disappointing data a few years ago with Rova-T. Do you think tarlatamab is the real deal?
I said my answer to that is yes. I think it's a well-conducted study. Has some obvious selection biases in the population, which may reflect why we've seen the observations. Whether, as Michael said, it's generalizable to the general population is waiting to be seen. So we need to see more data in the phase 3. I think it's certainly a very promising study. And I think I've also observed some of the early results compound as well. So there should be some consistency. Class of agent there.
I might throw this one out to you, Michael. Obviously, one of the issues in patients with small cell lung cancer is brain metastases. Is there data for tarlatamab in particular, but any of the DLL3 compounds with blood-brain barrier penetrance and activity?
Yeah, look, good question. And I think the honest answer is we don't really know how well these things are going to work in the brain. I mean, the study I talked about, and in fact the phase 1 trial, all allowed patients with treated brain metastases to participate. But of course they were treated stable brain metastases, and that's different than treating brain metastases de novo. There wasn't sort of major rapid progression in the brains of these people. But again, you don't really know to what extent tarlatamab was responsible for slowing down or preventing brain metastases in them. So I think the honest answer is we don't yet know.
Thank you, Michael. Rebecca, Beck, so say tarlatamab is available tomorrow. How will you roll this out at the Royal Hobart Hospital, which is a large tertiary center, but still will have potentially challenges?
Well, that's a great question, Surein, and that really was what I was thinking as Michael was presenting the data. Like, how do we roll this out in regional centres, and particularly given that, on study, many of the patients required, overnight admission for risk of CRS and ICANS as well. And I think with any new therapeutic, there is a learning curve as well. These are very new agents that, I think broadly speaking, outside of, tertiary centres, many of us may not have experience with. So, I think certainly there is a component of like education when we roll this out, like webinars like tonight, but also education of not just oncologists, but also the broader treating team. And I think we do need to be communicating the mechanism of this drug and symptoms to look out for and how to treat to the after hours doctors, to ICU, to other units who will be involved in care. So look, I think it will be rolled out and we can do it, but I'm not sure whether we're all prepared for it just yet.
Yeah. Michael, do you have any tips for?
Yeah, look, I would say it's probably not as easy as we would like it to be, but probably not quite as bad as what everybody is thinking at the moment. So first thing to say is that this is an issue, even if you're talking about admission, of the first cycle, maybe the first 2 cycles. It's not something that that is ongoing and is an ongoing problem. Secondly, the majority of these people really are treated purely symptomatically. With the most exciting thing, you tend to give them some IV fluids and some steroids. But of course, you do need to know what to do if it happens to be the small percentage of people who do have more serious problems. I think that that's where education comes in. And I think in reality, as in more and more large centres, you see things like CAR T therapies, you see other bites coming along. I think people will learn, but no question, there will be a bit of a learning curve to start with. I think also, by the way, that there is probably something you can do by partnering up with institutions that have a little bit more experience and that can therefore help provide advice and knowing how to treat and when to treat these complications.
Thank you, Michael. And while I've got you there, one of the questions from someone in the audience is, how do these compounds encourage tumor cell killing independent of MHC1? And what do you think the other mechanisms that might be contributing to tumor cell lysis?
Yeah, look, if I was an immunologist, I could probably answer that question. Look, I can have a little bit of a go. I mean, the fact is that compared to how the immune system normally works, this is a little different, because rather than requiring sort of antigen presentation in the context of MHC, I think the idea is that these molecules actually bind to the antigen, bind to the T cell, and activate the T cell all in one step. So you've gotten rid of the need for the thing that's normally the intermediary, the thing that's normally presenting the antigen. And so I think that's how it works. I don't know that I can give a better answer than that, but Kate's shaking her head, so she might know more than me.
I'm not an immunologist either, so I think you explained that beautifully, Michael. Yeah, I guess I'm curious, are you surprised at how effective it's worked when, maybe we wouldn't normally think that the T cells are there, like within the tumor? It kind of seems like that's not necessarily required.
Yeah, look, I think that's right. And I think that the other thing that's, I think we're in the infancy of this, and like many things in their infancy, we're making the observations at the moment, but don't really have the explanations for those observations. And, this works well, but it works well in 40% of people. We don't know what's special about that 40%. We really don't. It's clearly not just DLL3 expression, so it's not just that. Maybe it's something to do with their immune system rather than with the tumor. I think there's several years worth of work, and and we will maybe then eventually understand it.
Sagun, where do you see the new three different antibody drug conjugate targets you described? Where do you see that fitting in the field? Because naturally, I assume and imagine a lot of these drugs are going to be moved on into the earlier line setting. We've already seen studies that, in fact, Michael showed Delphi 304 being the second-line study randomizing tarlatamab against standard of care chemotherapy, and you showed one of the very similar studies. How do you think this is all going to play out?
Yeah, good question, Surein. I think it's going to follow the BITE story. So you're going to move these agents in the first line. You're going to combine them with chemotherapy, with immunotherapy, and then you're going to have to compare them with your standard of care treatment. I think the interesting thing in all these studies was that expression didn't really correlate with response. So even the non-expressors had responses. So how are you going to pick your patients and which drug you're going to give them, whether you give them a BITE or an ADC or chemoimmunotherapy, I think is going to be the challenge, and how we pick our patients. Obviously, Kate showed some nice work, retrospective work about the different molecular subtypes and whether we need to I guess, molecularly define our patients before we treat them and decide what treatment we give them. And Kate may be able to answer whether ctDNA has any role in small cell lung cancer and whether we use that in the future. But I think, yeah, everything's going to initially will have to be tested against the standard care treatment and then in combination.
Kate, do you want to comment on some of what Sagun sort of put forward, especially in terms of liquid biopsies?
This is not an area of my expertise, but my understanding is that small cell lung cancer patients have a lot of circulating tumor cells, I guess, given their high, generally high metastatic burden. So there has been a couple of recent studies and from some meetings that I've been to recently where people are now looking at circulating tumor cells and whether they can define the subtypes and the phenotype of the cells in the circulation of patients. So I think this is also definitely an evolving area of interest. And so I think from the data I've seen, I think it will be possible to at least subtype them. And again, I think that, whether how much that's going to guide treatment, I guess that's still, an unexplored area.
So Nick, we've seen that as has been pointed out in all these clinical trials, we're looking at a younger patient population. Delphi 301 had a patient population beyond third line, which is a fairly rare sort of patient. What is the general proportion of small cell lung cancer patients you see in your clinic, and how do you think this data is going to apply to the patient that you see tomorrow, the good old stock standard small cell lung cancer patient, if you like?
Good question, Surein. And I think in our population, they're largely symptomatic presentations, older patients, or the type of patient that you need to start treatment on quickly, haven't got a lot of time. This is in the first line setting, and haven't got a lot of time to sort of and put people onto a clinical trial. That's our demographic. Things might change. I was thinking as the presentation was going on with screening, obviously small cell patients are more likely to be smokers, whether we'll pick up patients in an earlier time point and get the prevalent cases in the community in the first phase of screening. That might certainly help pick better and fitter patients. Some of the things that I was thinking as the talk was going, and I must commend you and the team for such a great spread of talks, was we know as we've learned more, I think we have more questions and answers at the moment. I think Michael articulated that well. In Kate's presentation, we've been asking her about circulating tumor cells, but the stuff presented was largely around transcriptomics, and patients with small cell practical limitations, we often get the diagnosis on small biopsies. We don't often have a lot of tissue samples to actually do patient selection with. So we're going to have to start adapting some of the learnings from, I think, non-small cell in terms of tissue acquisition, if we are going to start to select these patients. I'm curious to know who the 17% are in the long-term survival, whether we can define those populations from immunotherapy, from the first generation immunotherapy trials. And I'm curious to know whether there is a selection marker of those patients who've survived those to get into third line that predicts for them to benefit. But as Kate says, there's an adaptability in the cells. Will the patients, is it automatic that you have to do well to get to third line? Can you do badly but still do well later? I don't know. I think there's a lot to learn. It's an exciting time, certainly, and you've highlighted it very well tonight. Thanks.
And maybe a question for you, Beck. So you've shown us all the beautiful data with first-line PD-1, PD-L1 therapies. Do you think it's a case of replacing them ultimately, or do you think we'll be potentially looking at combination strategies, ADCs plus IO, or tarlatamab plus IO even? What are your thoughts there?
I mean, that's certainly a trend that we've seen in trial design where you have your standard of care and you build upon that. I think what would be really nice to see is a more refined, more personalised strategy, even in small cell lung cancer. So, that speaks to, biomarkers. as well. And, you know, I think, as Nick mentioned before, we don't know who that 12% of long-term survivors are. So we don't know how we pick those patients out. And they're the patients who, you know what, I don't think we need to escalate treatment, but that's just 1 in 10 people with small cell. So for the other 9 out of 10 people, maybe dose escalation is the key. You know, I think stratifying treatment strategies with now we've got different drug types. I think that's the direction that we should be heading, to be more sophisticated than, you know, one size fits all. I think there's still, you know, there's so many interesting questions that have just come out of, you know, tonight, that, you know, certainly maybe the work for TOGA as well.
Yeah,
we can be involved in that.
Definitely. And maybe a sort of a final question. So maybe I'll turn to Kate initially. EGFR mutant transformed small cell lung cancer, actually any other oncogene transformed small cell lung cancer, is a real problem. We're seeing these patients. I suspect we're missing a lot because we're not always biopsying these patients. Do you think the biology is similar in terms of us being able to apply some of these therapies?
I was going to add a slide about that. Yeah, that's a really interesting question. So there was a study, I think, published a couple of years ago that looked at the transcriptomic profile of transformed small cell and compared that to non-transformed small cell. And there were some differences in the biology. One that I can recall off the top of my head was, I think, that the transformed small cell had sort of an Apperbeck signature, but the subtypes were still there. So you could still see ASCL1, NeuroD1. I think they, from my recollection, I think they also saw a POW2F3 subtype. So there's similar biology, but I think there's a few, also unique, some slight uniquenesses in it too, but definitely evolving. And I think we're seeing that too with prostate cancer, where you get neuroendocrine transformation. We're seeing the same molecular subtypes that we're seeing in small cell coming up in those tumors too. So I think there's some really interesting biology there that's overlapping between these diseases.
So Nick, Michael, perhaps a potential sort of TOGA concept, something along these lines.
Yep.
Yep.
There is actually one final question. This is a fantastic question, and this is a question for all of you, actually. So we know that lung cancer screening is about to come into play next year, and potentially we're actually going to also identify patients with early or maybe even locally advanced small cell lung cancer. I guess the question is that the question here is that, do you think that we will pick up more small cell lung cancer with screening?
I alluded to that in my conversation earlier. I think the answer is yes, because it's a higher smoking population. And so you, as we expect in screening, in the first few years, we'll pick up prevalent cases. It's obviously a faster moving disease, but we'll still capture them, hopefully with a greater opportunity to treat than what I've observed in my clinic, and I'm not sure how your clinics are. The acute symptomatic presentations are coming so late that you're just scrambling to try to get treatment into them quickly. So I'm hoping that it'll give us a greater window of opportunity to offer treatment to the patients and better outcomes in some of these new offers.
I agree. Although we probably should know the answer from some of the other screening programs happening around the world at the moment. I mean, someone must know already.
Yeah, no, I agree. I'm not 100% across the small cell pickup rate in those studies, but presumably there would have been a percentage of them identified. I think what will be interesting is for those patients who go straight to surgery and then you have to resect the small cell lung cancer, and potentially be managing some more of those patients. All right, so that brings us to the end of our discussion. I'm now going to show you the results from the poll. So with the first question, we'd asked how would you rate your current awareness of T-cell engagers? And I'm very happy that the unaware rate has dropped from 42% to 7%. Still a bit upset that 7% are still unaware of T-cell engagers after this talk. However, the good news is now 81% are aware. And interestingly, we've got actually tripling of those who are now adept at using it. So this is fantastic. The second question was, what is your expected mean overall survival time for patients undergoing DLL3 targeted therapy? And now we have more people targeting the 9 to 12 month range. Although I believe the official mean overall survival, though the data is immature, was officially 14 months from Delphi 301. The third question is, what are the symptoms of grade 1 CRS? Most people are still sticking with all of the above, which is the correct answer. The fourth question is, can you manage CRS in your center? And we went from 90% who said yes to 94%, but still with 6% who said no. And I think that's fair. I think this will be an interesting drug once it rolls out. And Michael summed it up beautifully. A lot of fear, but once we start going, we'll just keep going with it. And then number 5 is, how do you manage grade 1 and grade 2 CRS? And the vast majority now have said that that is going to be symptomatic management. So well done, Michael, for getting that across. And indeed, on the studies, tocilizumab use was very rare and only in those who had grade 3 or grade 4 CRS. In terms of the free text question, there were sort of 3 key takeaways that came out. One was medical staff requiring CRS training, especially the junior staff and our emergency department colleagues, etc. The second point made was that small cell lung cancer is not one disease. Fantastic, Kate. That's definitely something you got across. So it looks like it, but unfortunately, it's not as simple as PD-L1 versus the 10 different oncogene drivers. It's 4 different classifications, and what I got up from it is that there is no why. And then and of course the third point is refer for ADC trials and well done, Sagun, for also pointing it out, but certainly there will be other BITE-based studies as well. So all that being said, I want to thank our excellent speakers for making the time tonight to be here and to share with us your knowledge in what it has become a very rapidly exciting area. I didn't ever think I would say small cell lung cancer is an exciting disease to treat, but I think that hopefully we've been able to show that we are now really at the tip of the iceberg, and we're going to see a lot more data in the next few years. I want to thank Amgen for sponsoring this. Without that, this would not have happened. And finally, I want to thank Dilu and Megan, who are the key people behind the scenes that have helped actually really make this very successful. So thank you to both of you, and thank you very much, everyone, and good evening.